Hello everyone, my name is Kyle Sugg and today I'll be discussing the critical issue of lung cancer, which carries the highest mortality rate of all malignancies, implicated in approximately 20% of cancer-related deaths in the United States. According to the American Cancer Society's 2023 estimates, there are an expected 238,340 new cases of lung cancer expected this year, of which there is going to be an expected associated 127,070 deaths. The 2011 National Lung Screening Trial established a 20% reduction in lung cancer-associated mortality associated with annual low-dose CT screening compared to screening chest radiography. In 2013, the United States Preventative Services Task Force adopted this approach into their recommendations, with a subsequent update in 2021 establishing a recommended annual low-dose CT screening for those between the ages of 50 to 80 years old with a 20-pack year history of tobacco use, which either still smoke or have quit within the last 15 years. There remains a concerning lack of access to primary care physician-initiated low-dose CT screening, however, especially in medically underserved areas, negatively impacting the morbidity and mortality through relatively low early detection of lung cancer screening. Our study aimed to improve compliance with lung cancer screening per USPSTF guidelines in our resident-run primary care clinic. Throughout our first 15-week PDSA cycle, our goal was to achieve a lung cancer screening order rate of at least 50% of all eligible patients. We included any patient meeting the 2021 USPSTF criteria, as mentioned earlier, and excluded any of those who either had already received a low-dose CT screening in the last 12 months or did not meet the criteria. In the pre-intervention stage of this study, we established a new baseline rate of low-dose CT screening order compliance through chart review, which showed that approximately only 31.9% of eligible patients were screened appropriately. Our intervention involved an educational flyer which detailed the guidelines for lung cancer screening as discussed above, and placed in each clinic exam room to promote a patient self-assessment of the eligibility. The 15 weeks of post-intervention data showed a significant improvement in appropriate lung cancer screening rates with low-dose CT screening. We did achieve our goal of 50% lung cancer screening rate amongst all eligible patients, as our calculated post-intervention rate was approximately 59.4% of all eligible patients receiving an order for low-dose CT screening. Our success shows that using a simple intervention as a template, a clinic in any socioeconomic setting could benefit their lung cancer screening rates. As our clinic operates within an area with a disproportionately high level of low-income population, it was essential to our team that the intervention remain cost-effective, not only for our clinic, but for the patients. We did this easily through using printed flyers, allowing for patient-initiated involvement in their own healthcare decision-making process. However, we know that there's still room for improvement. As our project transitions to its next PDSA cycle, we plan to modify the intervention to reflect constructive feedback from both the resident physicians and the attending physicians, as well as the patients involved. Likely, these will include a macro attached to the end of our clinic note templates, consisting of USPSTF lung cancer screening criteria, and our goal for the next PDSA cycle will be at least a 70% rate of successful order placement among all qualified patients. In conclusion, lung cancer screening with low-dose CT has the potential to save many lives. Our study demonstrates the importance of patient education and empowerment in promoting appropriate lung cancer screening, and with continued efforts to improve access to low-dose CT screening, we can make huge progress in reducing the mortality rate of lung cancer. Thank you.